हेलो फ्रेंड्स। अब ईसीजी का आज हम थर्ड पार्ट स्टार्ट करने जा रहे हैं, तीसरा सीरीज। और इसमें हम बंडल ब्रांच ब्लॉक देखेंगे। बेसिकली आज हम डिस्कस करेंगे लेफ्ट बंडल ब्रांच ब्लॉक और नेक्स्ट वीडियो में राइट बंडल ब्रांच ब्लॉक। इन आप जितने भी ईसीजी के वीडियोस पढ़े हैं ऑन दी इंटरनेट, दिस इज द मोस्ट एग्जॉस्टिव कवरेज ऑफ लेफ्ट बंडल ब्रांच ब्लॉक। ओके, none of the videos have discussed left bundle branch block in this much detail. So start करते हैं left bundle branch block. Okay, so before starting left bundle branch block we have to know how depolarization current is formed. Okay, we all know that this is your heart which is divided into, this is your right atrium, this is your left atrium, this is your left ventricle, and this is your right ventricle. Here it is SA node, here it is AV node. So depolarization current, that is SA node fires the current which travels from the SA node to the AV node, and then through the AV node it travels through the bundle of his, and then in the right bundle branch, and then it travels into the left bundle branch, and left bundle branch is further divided into a posterior fascicle and anterior fascicle, and it then depolarizes whole of the left ventricle, and this right bundle branch depolarizes whole of the right ventricle. This is a normal depolarization. This is bundle of his, and the normal length of bundle of his is 1.8 centimeter in the adults. Now, before understanding this diagram, these are some important points that you should know. Now, what happened if now come to this diagram? This is AV node. Okay, this is AV node. This part is the interventricular septum, this part is left ventricle, and this is the free margin or the lateral margin of the left ventricle. This is the right ventricle, and this is the lateral wall of the right ventricle, and this region is the apex. Okay, so first, once the AV node is depolarized, it depolarizes these, and this is the septum. So once the AV node is depolarized, it depolarizes the septum. And always remember, the direction of depolarization of the septum, as is marked here, is from left to the right. It is from left to the right. So depolarization of the septum is from left to the right. This is very important point. Please understand that septum is depolarized from the left to the right. Now we'll see what is the, why I am stressing on this point. Now, since the septum depolarization occurs from left to the right, if we take any lateral lead, I have already told you that lateral leads are lead 1, AVL, V5 and V6. Let's take lead 1 for example. If we see lead 1, which is a lateral lead, that means it is seeing the heart from here. So the depolarization will be towards the left, from left to the right. So lead 1 will form a small negative deflection, because any lead, if the direction of depolarization is towards the lead, it measures a positive deflection, and if the direction of depolarization is away from the lead, it measures it as a negative deflection. So this septal depolarization is from left to the right side. So a negative deflection will be recorded by the lead 1, which is a lateral lead, and also in lead AVL, V5 and V6. So this will be a small negative deflection which will be known as Q wave. This is very important. So the cause of Q wave in lead 1, AVL, V5 and V6 is because the septal is depolarized from left side to the right side. Okay. Now, once we understand this, we know that normally, that means if there is presence of Q wave in this lead 1, AVL, V5 and V6, we cannot say that it is a pathological Q wave. And Q waves are normally present in lead 1, AVL, V5 and V6. Now, if we look at a lead V1, V2, V3 and V4 and AVF, I have already told you that lead AVF is an inferior lead. In the second lecture, I have told you that AVF, F for floor, it looks the heart from the lower side. and the other two leads are lead 2 and lead 3. Therefore, these are known as inferior leads. So AVF directly looks the heart from the inferior side. Now, understand this. The direction of depolarization is this. Therefore, when AVF will see the direction of depolarization, it will be around 90 degree. And no lead is able to measure a depolarization if it is at 90 degree to its direction. So septal depolarization is like this, and lead AVF is looking from this side. So direction is around 90 degree. So there is no Q wave in lead AVF. Okay. So Q wave will not be present in lead AVF. Now what about V1, V2 and V3? Now V1 is a right-sided lead. Okay. So V1 is a right-sided lead. So right-sided lead, the direction of depolarization will be towards the V1. So there will be no negative deflection. Therefore V1 will never have a Q wave. This is the second important point. Now see, that's why I am saying it is very important to understand the direction of depolarization of the septum is from left to the right. Now coming to the V2 and V3. Now V2 and V3 are the anterior leads. They are present, V2 is present here and V3 is present here. V2 is present here and V3 is present here. So they are almost 90 degree to the septum. Therefore they are also not able to record this septal deviation. Therefore in V2 and V3 we will not be having Q waves. So what is the final take home message? That because of the septal depolarization, the lateral leads see the septal depolarization from left to the right, and since it is going away from the lead, they measure a small Q wave. That is, so a Q wave will be present in lead 1, AVL, V5 and V6, which are lateral leads. It is not a pathological Q wave. Now, and Q wave will never be seen in lead AVF, V1, V2, V3. Why AVF? Because AVF is the inferior lead. It is looking the heart from the inferior side, and the direction of depolarization of the septum will be from left to the right. So it makes an angle of 90 degree. So there will be no Q wave in AVF. And V1 is a right-sided lead. So the direction of depolarization will be towards the V1. So there will be no Q wave here. Here directly there will be R wave. And V2 and V3 are they are just in front of the septum, that is 90 degree in the front. Therefore they will not able to record the septal deviation. So there will be no Q wave in lead V2, V3. So what is the point of understanding these things? The point of understanding these things is that now we can define what is a pathological Q wave. When we will say that this lead is a pathological Q wave, so following points must be present if we say that this Q wave is pathological. If Q wave is present in V1, V2, V3 or AVF, if the Q wave is present in any of these leads, then we will say that it is a pathological Q wave, because we know normally in these leads, in normal depolarization they cannot detect septal depolarization, they cannot detect Q wave. But if they are detecting Q wave, that means it is a pathological Q wave. First point. Second point, if Q wave width is more than 1 millimeter, a small box, that is around 40 milliseconds. So if the lead Q wave width is more than 1 millimeter, or if the depth of Q wave is more than 2 millimeter, then we will say it is a pathological Q wave. Or if the QRS depth is more than 1/4 of QRS height. If any of these things is present, then we will say that this is a pathological Q wave. That's why whenever the Q wave is present in lead V1, V2, V3 and AVF, we say that please look, because in these leads only pathological Q waves are present, and physiological Q waves are present in lead 1, AVL, V5 and V6. It is a normal finding. I have told you why, because these are lateral leads and they see the septal depolarization from left to the right, and they see the septal depolarization from this side, so they mark a negative way. Now, very important point, in left bundle branch block, what happened that there is a blockage in the left bundle. So now if we see the septal depolarization, normally septal depolarization is here from left to the right here, but because there is a left bundle branch block, now there will be no left to right depolarization, there will be reversal of the septal depolarization, and then now it will be depolarized from right to the left. Okay, so in left bundle branch block, the normal septal depolarization which takes place from left to the right is reversed, and septal is depolarized from the right to the left side. Therefore, in lateral lead, especially V5 and V6, will you able to see Q wave? No, because you know that V5, V6 and lead 1 AVL, these are lateral leads and septal depolarization occur from left to the right, therefore they record a negative Q wave. But in case of left bundle branch block, the septal depolarization is reversed. So now the depolarization will be like this. So they will not record a Q wave. So absence of Q wave in V5, V6 is a criteria for the diagnosis of left bundle branch block. So when you will study the criteria for the diagnosis of the left bundle branch block, you see one of the criteria is absence of Q wave from V5 and V6. But I am telling you the exact reason why this is one of the criteria, that absence of Q wave from V5, V6 is taken as a criteria for left bundle branch block, because the septal depolarization is now from right to the left. So now coming to the next point. So initially normal direction is from left to the right, because of which we get a Q wave. So once septal depolarization occurs, next wave of depolarization is in this direction, that is from the base towards the apex, from the base towards the effect. Therefore, if we see, for example, if we take lead AVF or even lead 1 or lead 2 or lead 3, this direction of depolarization is towards this lead, so they will record a positive R wave. So due to septal depolarization, there was a negative Q wave. Then because of the depolarization of the septa from base to the apex, a positive R wave is generated. Okay, so the cause of R wave is the septal depolarization from base to the apex. Okay, now after that there is depolarization of the left ventricle and the right ventricle, and the direction of depolarization is from endocardium to the epicardium, Now this direction, if we take lead 1, understand in all the examples we are taking this lateral lead 1, okay, as a reference. So this depolarization of the left ventricle from endocardium to the epicardium is very weak, almost zero. Therefore, generally its activity is not recorded. But sometime, since this direction is from right to the left and lateral lead 1 is here, so it may record a notch here. Okay, so sometimes you see a notch in this R wave. It is because of the depolarization of the left ventricle wall from endocardium to the epicardium. Then it comes down. Now in the final, this part is known as the basal part of the left ventricle, or the free margin part of the left ventricle. This part depolarized in this direction. Okay, so if we take lead 1, this part is going away from the lead 1, so you again see a S wave. Okay, so the cause of Q wave is septal depolarization from left to right. The cause of R wave is the depolarization of the septum from base to the apex. The cause of this notch, which is sometime present, is the depolarization of the left ventricle free wall from endocardium to the epicardium. It may or may not be present. And the cause of the S wave is the depolarization of the uppermost part, or the basal part. Note, this part is known as basal part and this part is known as apex. Okay, so don't get confused. This is the upper part or the basal part. So S wave is formed because of the depolarization of the basal part. So this is the basic knowledge why the different, and we have discussed all these things with respect to lead 1. Okay. So once we have known this, now we'll come to the left bundle branch block diagnosis. So diagnosis, there are basically 5 points: first, second, third, fourth and fifth. I'll explain you each and every. The first point says that QRS should be more than 120 milliseconds. Now we know that normally it is bundle of his. This is right bundle, this is left bundle, and then the right bundle depolarizes the right ventricle and the left bundle depolarizes the left ventricle. Now since there is a left bundle branch block, the normal depolarization of the left ventricle takes less than 120 millisecond or less than 3 small blocks. But since there is a block, so this area will also be depolarized from the right side of the heart or the remaining part of the septum. So it will take more time for the depolarization. So now the depolarization time will be equal to or more than 120 millisecond or 3 small blocks. Okay. So this first criteria, that is QRS duration should be equal to or more than 120 millisecond, is the first criteria that you should see in case of left bundle branch block. And this is the only common criteria which will also be seen in right bundle branch block. And the same concept will be applied. In right bundle branch block also, the QRS duration will be more than 120 millisecond. Okay. So after knowing this, second point. The first point is QRS duration should be or equal to be more than 120 millisecond. Second point, we have to see lead V1. Okay, in lead V1, now understand it very clearly. You will see a deep S wave. Okay, you will see a deep S wave, and R wave is so small that most of the time it is not visible, and you can mistook that S wave to be a Q wave. I am explaining you like this. Okay, so in lead 1 you will see a very large S wave, and R wave will be so small that you can mistook this S wave to be Q wave. Okay, so this is present in lead V1 and maybe present in lead V2, but we have to see lead V1. So this is the second point. First point, QRS duration more than or equal to 120 milliseconds. Second point, deep S wave and R wave may be present, but generally it is not seen. So we may mistook this S wave to be equal to Q wave. This is the second point. Now coming to the third point. So see, like this. You see, this is lead V1. Okay, this is lead V1. We have a deep S wave in lead 1, and you see there is R wave, but it is not visible. So you can mistook this wave as a Q wave. So please understand this finding. I am repeating it because once you will look into the ECG, you will remember that why these points are so important. So the third point is dominant S wave in lead V1, and this dominant S wave in lead 1 may be preceded by a small R wave, but this R wave is so small that this S wave will look like a Q wave, and this is known as RS pattern. Okay, you don't have to remember this RS pattern, you have to remember what I am telling because that is important. Now coming to the third point, broad monophasic R wave in lateral leads. This is very important. What is broad R wave? Don't look into this. In third point, look into the lateral leads like lead 1, AVL, V5 and V6. Okay, lead 1, AVL, V5 and V6. What you will see? You will see a broad R wave. First point, you will see a broad R wave. What is the meaning of broad R wave? Broad R wave means there will be no Q wave, there will be no S wave. So a wave like this is known as a broad R wave, which may have 3 kinds of pattern. Please remember, this can have three kind of pattern. The first pattern, that is this broad wave may be notched. It may have a notch. So first is this broad wave may be notched. Second, this broad wave have no notching, nothing. So this is known as monophasic R wave. Third, this R wave can have M patterns. Please remember, these are the three kind of R wave that you can see. So broad R wave means that is it will be like this. There will be no Q wave, no S wave. And second thing, this is the first point. Second point, it may have a notching. It doesn't have any notch, then it will be called as a monophasic R wave. And third, it can have a M pattern. So now you will understand the meaning of broad monophasic R wave. But this is not complete. Broad means this R wave will not be having Q wave or the S wave. Second, it can be monophasic, that is no notching, no M wave. Second, it can have notch, or third, it can have a M pattern. Now like this is a broad R wave. See, this is also a broad R wave. This is also a broad R wave because they don't have a no Q wave, no S wave. Okay. So this is a broad R wave. But there is a difference. In this R wave, there is no notching. There is no notching or M pattern. So this is called as a monophasic broad R wave. This is a monophasic broad R wave. In this, there is a notching present. So this will be called as a notched broad R wave. All are taken as a left bundle branch block. And this you are seeing a M pattern. You are seeing a M pattern. So this is a broad R wave with M pattern. So R wave can be broad R wave, that means no Q wave, no S waves, but it can be notched, it can have a M pattern, or it can be simple monophasic. All will be taken as a left bundle branch block. So we are having three criteria: QRS equal to more than 120 millisecond. Second, in V1 we have a deep S wave which is preceded by or R wave which will be so small that S wave can be mistook as a Q wave. And in third, we will be having broad R wave which can be monophasic, notched, or M pattern in lateral leads. Then absence of Q wave in lateral leads, mainly V5 and V6. I have already explained the reason why the Q waves will be absent from the lead V5 and V6 in left bundle branch block. If these four things are present, then you will label that ECG to be a ECG of left bundle branch block. But secondary findings can be PRPT of more than 60 millisecond. What is PRPT? Now, normally, if we say this is Q wave, this is R wave, S wave, okay. So this is Q wave, so and this is R. So starting of the Q wave till the peak of R wave, generally this time duration is less than or equal to 40 milliseconds. I am again repeating, starting of Q wave to the end to the peak of R wave is generally 40 milliseconds. If the time duration is more than or equal to 60 milliseconds, then we say that PRPT is increased. That is, there is prolonged R wave peak time. That is known as PRPT. PRPT, prolonged R wave peak time. That means from the starting of the Q wave till the peak of the R wave, the timing is 60 millisecond or more, which is equal to 1.5 small box. Okay. This finding may or may not be present, but if these four things are present, we will say that patient is having left bundle branch block. Now, what are the causes of left bundle branch block? Please remember this mnemonic: A2, H3, D1. Okay. A is for anterior wall MI. Next, A is for aortic stenosis. H is for hypertension. Next H is for hyperkalemia, and next H is for heart failure due to any other cause, and D is for digoxin. Okay, these are the causes of left bundle branch block. Now, very important point. The most disastrous cause of left bundle branch block is anterior wall MI. Okay. So hypertension you can diagnose with the help of the clinical features, symptom signs. Hyperkalemia by simple test. Heart failure you can diagnose by echo, by examination. Now, very important point is when you get a left bundle branch block in ECG, the major concern is to differentiate this anterior wall MI from other causes of the left bundle branch block. Therefore, there was a scientist whose name was Isgar-Bosa. The name of the scientist was Isgar-Bosa, who find a criteria which is known as Isgar-Bosa criteria, which help us to differentiate a ECG of left bundle branch block, that this left bundle branch block is caused by anterior wall MI or is because of the other causes of left bundle branch block. So Isgar-Bosa criteria help us to know that this ECG of left bundle branch block is because of anterior wall MI or not. So we have to study Isgar-Bosa criteria. Before studying Isgar-Bosa criteria, we have to solve 1-2 ECGs of left bundle branch block to understand it. Now, this is the ECG in front of you. This is a case of left bundle branch block. Now, again, the first thing was QRS duration was more than 120 millisecond. Okay. Sorry, first ECG is this. Okay. So our first point was that QRS duration should be more than or equal to 120 milliseconds. Now see, this maybe it is not visible to you, but the duration is more than 120 millisecond. That is 3 small box. So first finding is clear. Second finding was in lead V1 we will see a deep S wave which may be preceded by R wave, but R wave will be so small that we can mistook that this S wave to be a Q wave. So see, this is a very big S wave, and R wave is present but it is very small, that people may call it a Q wave. Okay, so this is a deep S wave and a very small R wave. Okay, so third finding was we will see a monophasic R wave, that is it will not be having Q wave, neither having S wave, and it can be a monophasic or it can be present with the notch or M. Now see this lead one, this is a monophasic R wave, no Q wave, no S wave, and there is a notching present. So yes, third point is also confirmed. Now if you see lead V5 and V6, there is no Q wave. Thus we can say that this is a case of left bundle branch block. In the first step it may be looking very difficult, but when you will solve more ECGs you will be able to understand that these are the cases of left bundle, how to solve left bundle branch block. Okay. Now we will come to Isgar-Bosa criteria. But what is Isgar-Bosa criteria? Before understanding Isgar-Bosa criteria, we have to understand some points. Don't look these things. Now you have diagnosed the case of a left bundle branch block. Now you have to diagnose whether it is because of anterior wall MI or not. First understand, initially I have told you that if this is our QRS complex, we have to calculate R minus S. R is the height of QRS above the baseline, S is the depth of the QRS below the baseline. It can come 0 or positive, or it can come negative. Okay. Now we have to understand 3 important terms. First term, concordant ST elevation. What is the meaning of concordant ST elevation? Concordant ST elevation means ST elevation is present. What is the meaning of concordant? Concordant means that R minus S is positive. R minus S is positive. That is net QRS is above the baseline. For example, see this ECG. Here it is ST elevation. We have a ST elevation here and R minus S is positive. Actually there is no S, so R minus S is positive. So this will be called as a concordant ST elevation. That is, there is ST elevation and R minus S is positive. That is, net QRS is above the baseline. Then we have to understand second term. Second term is discordant ST segment elevation. So this term is also telling that there will be an ST elevation, but what is the meaning of discordant? Discordant means R minus S will be negative. That is, net QRS will be below the baseline. Now see this. This is ST segment elevation, but if we calculate R minus S, this is R, this is S. It is negative. So this is what? This is the case of discordant ST elevation. Okay, this was concordant ST elevation along with R minus S positive. This was discordant ST elevation, that is ST elevation with R minus S negative. Then there will be a third term that will be called as concordant ST segment depression. And this term is also self-explanatory, that there will be ST depression, but R minus S will be negative. See this. Here we have ST segment depression, and this is R and this is S. R minus S is negative. So we will say that this is discordant ST segment, the concordant ST depression. Now see, in concordant ST segment elevation, R minus S was positive, but in cases of concordant ST segment depression, R minus S was negative. Okay. So again I am telling you, in this diagram, here what we see, there is ST elevation and R minus S is positive. So this is concordant ST segment elevation. This is concordant ST elevation. Here there is ST segment elevation, but R minus S is negative. So this will be discordant ST segment elevation. And in this case there is ST segment depression, but R minus is negative, so this will be concordant ST segment depression. So we have to understand these 3 points very clearly. Concordant ST segment elevation, discordant ST segment elevation, then concordant ST segment depression. If we understand this point, then we can understand is Garbosa criteria. What is Garbosa criteria? Garbosa criteria says it specifies different number to these things. For example, concordant ST segment elevation of 1 millimeter in any lead will be given a point of +5. Okay, concordant ST segment elevation of 1 millimeter in any lead will be given +5. Discordant ST segment elevation of 5 millimeter. Please remember, this is taken as 5 millimeter in any lead is given a point of +2. I will be telling you why we are taking here elevation of 5 millimeter and we are just giving a point +2. Then concordant ST segment depression of 1 millimeter in lead V1, V2, V3 is given a point of +3. Then we will add all these points. If we get a value of +3 or more than +3, then we will say that there is high chances that this left bundle branch block is most probably caused because of the MI. Otherwise, if the value is less than 3, then we will look for the other causes of left bundle branch block. Now you are seeing that concordant ST segment elevation of 1 millimeter in any lead is given +5 point. This is the most important. then discordant ST segment elevation of 5 millimeter in any lead is just given plus 2 point. Why? Because when we see an ECG of left bundle branch block, we have seen that in lead V1 we see pattern like this, that a very small R wave and a very deep S wave, and there is a follow, and then there is a ST elevation. So what pattern this is? This pattern is R minus S is negative and there is ST segment elevation. So this is called as discordant ST segment elevation. So in a left bundle branch block, invariably discordant ST segment elevation is present. Therefore, this criteria is not given high weightage because it is normally present in the left bundle branch block, and it is taken significant only and only if this ST segment elevation is of 5 millimeter. That's why see here it is written 5 millimeter. Okay, so discordant ST segment elevation is not given much weightage because discordant ST elevation is invariably present in left bundle branch block, and it is given only weightage, it is given only plus 2 point if this ST elevation is large, that is around plus 5 millimeter. And then there is a third point, that is concordant ST depression, that is this we see only in lead V1, V2, V3, and then we add if the value is 3 or more than 3, then the left bundle branches possibly because of the MI. Now this is a very important case. First, if you guess this ECG, I have already marked here, but if you get this ECG, you are seeing that QRS, this is QRS. QRS is more than or equal to 3 small box. First thing is fulfilled. Second is that in lead V1 we will get a deep S wave which is preceded by a R wave. R wave is generally so small that this S wave is mistaken as a Q wave. Okay? So see this deep S wave. Yes, deep S wave. See, sorry, lead V1 is this deep S wave, and R wave is present but very small, so you can mistook this as a Q wave. So second point is also valid. Third point is you get a broad R wave in lead 1 AVL V5 V6. So see this lead 1, this is lead V6, broad R wave, किसी भी एक लीड में मिल जाए V5 V6 1 AVL. Okay, so this is a broad R wave. V6 में देखिए आपको मिल गई broad R wave. Now this R wave can be monophasic. Now here it is a small notch here, so this is notched. So third point is also valid. We are getting a broad R wave, that is no Q wave, no S wave, plus we are getting a notch. So 3 points are valid, and QRS duration is more than 120 milliseconds. Now if we see lead V5 V6, there is no Q wave in V5 and V6. So all the 4 points are valid. So we will say that this is the ECG of left bundle branch block. Always go by this dictum: QRS duration, then lead V1, then look for the broad R wave with notch or M pattern or monophasic in V5, V6 or 1 or AVL, and then Q wave, and diagnose this as a ECG of left bundle branch block. Now you will apply Is-Garbosa criteria in this. For Is-Garbosa criteria, if you look, you have to look for first concordant ST segment. Is there any where concordant ST segment elevation is present? Yes. If you see this ECG, this part here, R minus S is positive because this is R and this is small is S. So R is, see here, R is greater than S. So there is net positive QRS. R minus S is positive, and there is ST elevation. This is the ST elevation, this part. Okay, so this patient, so there is R minus S is positive and there is ST elevation. So this is known as concordant ST elevation, and presence of concordant ST elevation gives how many point? Plus 5 point. And plus 0.5 point is, that means this left bundle branch block is possibly because of the MI. So this is how you apply Is-Garbosa criteria. It may be difficult initially, so but you have to understand. Now see this ECG. This is the ECG of left bundle branch block. Again, I am telling you. Okay, this is a paced rhythm. Now, if you apply Zaragoza criteria here, what will happen? First, I'll tell you that it is a left bundle branch block. If you see QRS duration, see this. So it is around 120 millisecond. So first point is fulfilled. Second point is look at the lead V1 or V2 where we have a deep S wave. So here if you look in the S wave, you have a deep S wave here. See this. And a very small R wave which is absent in lead V1. So deep S wave and a very small R wave. So second criteria is fulfilled. Now you look for broad R wave in lead 1 AVL. So if you see AVL, we have a broad R wave, and it is neither notch, neither M shape. So it is monophasic. So this kind of R wave, broad R wave, is called as a monophasic R wave. So it is a broad monophasic R wave. Then there is no presence of Q wave in V5 or V6. That means this is an ECG of left bundle branch block. Now once you have understand that this is the ECG of left bundle branch block, now we will apply Zaragoza criteria on this ECG. Here I have not marked. You can stop the video and you can apply. Now first we look for concordant ST elevation. Is there anywhere ST elevation present? No. So concordant ST elevation is not present. Now we'll look for discordant ST elevation. Since there is no ST elevation, we cannot look for discordant ST elevation. Is there ST segment depression? Yes. Here ST segment depression is present. So we'll look for concordant ST segment depression. What is concordant ST elevation depression? ST segment depression? That means R minus S should be negative and there should be ST segment depression, but only in lead V1, V2 and V3. So if you look at the lead V2, this is R, this is S, so R minus S is negative and there is ST segment depression and this lead is V2. That means this is a case of concordant ST segment depression. And how much point we give it? We give a point of 3. That means there is high chances that this left bundle branch block is possibly because of the MI. So this is how we apply Zaragoza criteria and left bundle branch block. If you have any, I will in the 5th or 6th ECG lecture I will be solving a lot of questions. Then again I will discuss these things in ECG. Okay. Thank you.